It's my great pleasure now to introduce the next speaker, Professor Ben Carlson, who was my teacher in gamma knife radiosurgery, and now he's a great friend of colleague. Yeah. Ben is one of the giants in the world of gamma knife radiosurgery. He hails from Stockholm, Sweden, and was previously head of the Karolinska Gamma Knife Center there. And for the neurosurgeons in the audience, we all know that the Karolinska or Sweden is the spiritual home of gamma knife radiosurgery, right? After the Karolinska, I think he moved on to Frankfurt to work for a while, and finally in the United States, where he was full professor of neurosurgery at the University of West Virginia from 2004 to 2009. And then he shifted to Singapore. Yeah, Ben has always liked Singapore, yeah, ever since he taught us gamma knife in the 1990s. Yeah. So he's always wanted to come to Singapore, and he made that move in 2009, and now he's a permanent resident here for the last 12 years. Yeah. So what's the Karolinska's loss is Singapore's gain, and in particular for NUH. Yeah. So Ben has a PhD in physics, and his PhD was also on AVMs and gamma knife treatment for that. And he's a very, very well published neurosurgeon. Like I said, he's done more than 7,000 cases. Yeah, he has a H index of 33, I index of 49, and 16 of his seminal gamma knife radiosurgery articles have been referenced more than 100 times in the literature. And 28 of his articles have been referenced more than 50 times, right? So today I've asked him to talk on gamma knife radiosurgery for brain mets, yeah. And I think for the non-neurosurgeons in the audience, and I think that's the majority of you, maybe I should say a few words about gamma knife radiosurgery. Yes, it uses radiation, but the gamma knife was actually invented by a very visionary neurosurgeon, Professor Lars Leksell in Stockholm. So it's been very much a neurosurgeon's tool, right? Even though it uses radiation, right? And he conceptualized it in the 50s. There was a real machine in the 60s, and then it sort of became very popular in the 1990s onwards because it became something like a magic tool that you could treat brain tumors without even opening the head, right? So in Singapore, we've had a gamma knife since 1995, yeah, and I've been doing gamma knife since that time. And at that time was located in Singapore General Hospital in the old radiotherapy building. I think many of you here are so young, like Prof. Chia and all that, you probably wouldn't know that I spent so many years there. Today that building, that site is now where your academia is, you know, right? So I spent 10 years doing a lot of gamma knife there with Ben at that time, yeah. And so it just blossomed throughout the world. Yeah, if neurosurgeons have a tool that can do neurosurgery non-invasively, you can see it caught on in the 90s, hundreds of units around the world. So it became a very popular Swedish export like IKEA, Volvo, and ABBA, yeah. Except it cost maybe $5 to $6 million, right? So it's been very much a neurosurgeon's tool, and I think even in the Karolinska, it's done totally by neurosurgeons without any input from the radiation oncologists. So I think it's quite appropriate that it's a topic that is discussed at today's Surgical Oncology Symposium. Yeah. So when Jimmy asked me to find two speakers for the neurosurgery section, and he told me the themes were on immunotherapy, so I got the great David Ashley to speak on immunotherapy today. And I got Ben to speak on gamma knife because the new gamma knife now relies on robotics. The old version was not robotized at all, yeah, so it would be impossible to treat, let's say, the 50 or 60 brain mets which we now treat routinely nowadays. So it's thanks to robotic technology that we can now treat multiple brain mets, which is the talk of Ben's topic today, right? So I think the treatment of brain mets, and you know, brain mets is very common. I think, in fact, it's the most common brain tumor, right? So about a third of patients with brain mets, particularly those with breast, lung, and melanoma, will have brain mets. And I think I've been in this game long enough to see the initial nihilism with a patient at brain mets, and then later on we had a randomized control in trial in the 90s to show that surgical excision of a single brain mets followed by whole brain RT was better than whole brain RT alone. To right now, the treatment, I think the current state of the art is actually just to use radiosurgery alone or gamma knife in particular. And I think in the past it was considered heresy for us to treat, let's say, multiple brain mets more than 20 with radiosurgery alone. But I've also seen that has now changed, and actually we here at NUH are really quite cutting edge. And I think recently we treated a patient with even 79 and another with 83 brain mets. And I think that's fast becoming accepted as standard of care instead of very old-fashioned whole brain radiotherapy, which is a therapy that's existed since the 1950s. So we hardly give whole brain RT anymore here for NUH patients, and I think our patients get a really, really good state-of-the-art care with gamma knife radiosurgery. So it's my great pleasure to introduce Ben Carlson to speak on a topic close to his heart, on which we published quite a lot in the literature, on gamma knife radiosurgery for brain mets.
Thank you very much, Sheng-Sai, for those kind words. Residents who rotated here surely have noticed that the philosophy using radiosurgery for brain metastasis varies between hospital and hospital. And I concur with Sheng-Sai that the gamma knife surgery probably contributes to that. But I also think it in a historical review to see why this is the case, and I do think we can explain part of this today. As Sheng-Sai mentioned, the old gamma knife was, to see to the left here, was completely manual, so each ISOS center was set manually, which was time-consuming and quite stressful for the patient. The new robotic machine is you dock the patient and the machine does the rest, so it's easy for the patient and it had a lot of advantages. So the clinical relevance is that it's easy for the patient and you save time. And this time saved, you can use either to use the more conformal dose plans, which means to reduce radiation to the normal brain tissue, which probably should decrease the risk for side effects. But you can also use it to treat more lesions. Of course, this eliminates the risk for human errors, but instead we have the risk for computer errors. But the good thing is the computer doesn't work, so neither does the gamma knife, so you cannot treat erroneously. Oh. Sorry. There we are. So that means that if the computer system doesn't work, you can't treat. And so far, that has not happened since inauguration December 2016. This is a slide showing the number of patient brain metastases treated in the gamma knife in Singapore. And you can see the last few years the number has increased, which probably means that we do treat more patients with more tumors, but of course there may be other explanations as well. What is important to underline is that gamma knife surgery is a multidisciplinary treatment, and the input to neuroradiology from radiation oncology, from medical oncology is necessary to optimize the treatment for every patient. And I'm happy to say we have a really good collaboration here, and I'm proud to be part of the team. Especially I appreciate the support from the radiologists. These are some texts, and they're really helpful when we ask for different sequences and time-consuming exams. They are happy to help us, which certainly increase the quality of the treatment. So thank you so much, radiology. As Sheng-Sai mentioned, the gamma knife was introduced in 1968. To the left, you can see large Excel with the first prototype. And the first publication about AVMs was published in 1972, 4 years later. It took almost 20 years until we published the first paper about brain metastasis. Why so long? One reason is obviously imaging. Actually, the Karolinska in Stockholm got the third gamma knife in the world, the third CT scanner in the world. But you can see to the right that the quality of those images are far worse as compared to today. But I think the main reason was Lars Leksell himself, because he was a strong opponent against treating malignant tumors in the gamma knife. Actually, his resistance was so strong, so it was shared with all his colleagues in the first generation of gamma knife users. I started using gamma knife in 1985, and a couple of years later, Christer Lindquist, my boss, left for US. So in order to learn about the technique and the results, I actually went through every single patient treated in the gamma knife, and I stumbled on this patient, a biopsy-verified metastasis of malignant melanoma, treated with a whopping 100 gray. The thinking in those days were that you have to give a very high dose because there are tumor cells in a radio-resistant phase, and thus you need to give a very high dose, which they did. 2 years later, you still see the tumor. 4 years later, the CT scan was normal. And the note from the doctor there shows the importance of this dogma, because he wrote, patient doing well, patient cured, no need for further follow-ups. Instead of thinking, wow, we cured an incurable disease with a single outpatient treatment, that is amazing. You see, 12 years after treatment, you still see a small rest, a small scar of the treatment, but as you can see, this tumor was cured. So when I saw this, I said to Christer, why don't we start to treat patients with gamma knife instead of operate them? And he was against, again, because of the dogma of large XL. But the advantage was so obvious. It's a non-invasive outpatient procedure. You don't need general anesthesia. There are very few short-term complications. And maybe more importantly, we can treat more lesions. When I was a resident, we operated one metastasis. Multi-metastasis want not to be touched. And I found this study from 1988 claiming that 90% of all patients has up to 4 brain metastases. Oh, so then I thought, why don't we hit the upper limit of 4? Because if we do so, we can treat 90% of the patient population. And said and done, that was the limit we decided on, and that still is a limit in some places in the world. As you can see here, it was a smashing success in Stockholm. The number increased exponentially to 1994, where I left for Germany. When I came back, the number increased again. And the first publication we published was 26 patients, and all but one of them responded to the treatment. We did omit whole brain, not because of academic thinking, just because we extrapolated the treatment from benign tumors to the treatment of metastasis. When I was in Germany, the gamma knife for radiosurgery was not reimbursed for patient brain metastasis. So I did a literature search, and this shows the number of publications dealing with radiosurgery of brain metastasis. And you can see in the early 2000s, there was an overwhelming literature evidence about radiosurgery. And this slide shows the local tumor control rate in all those papers. And you can see the far majority of papers report between 80 and 100% local tumor control rate. So a controversial question then, and sometimes, or maybe what's today, is the role of whole brain radiation. Can we omit that or not? And a good reason to give whole brain was that it was standard of care. And then, since I mentioned the Pachel study, randomized surgery versus surgery plus whole brain, showing a significant benefit if added whole brain. And many people thought that radiosurgery and surgery are the same, and thus this applies also following radiosurgery. And now multiple papers showed an improved local tumor control rate. We didn't disagree with that simply because we gave so high doses, so any further radiation wouldn't have made any difference. But maybe more importantly, at that time, there was no documented increases for complications and no documented increase of neurocognitive impairment. Actually, the opposite. Several papers quoted that the control of the tumor is more important for the neurocognitive function than the radiation damage that may cause following whole brain. This is a paper from 2005, the ASTRO guidelines, the evidence-based medicine. And it showed, as you can see here, there was no evidence of prolonged survival if you give radiosurgery instead of whole brain. And that omission of whole brain results in poorer intracranial disease control, and no documented impairment of neurocognition, and no increased toxicity. But they did recognize for a single metastasis, if you use radiosurgery on top of whole brain, the local tumor control rate improves. This is a paper published 2009, and just to show the dogma in those days, this is the comment from one of the reviewers, and he or she wrote, as you can see there, that we draw on our extensive experience on the treatment of AVMs, but fail to cite any of the prospective studies show minimal added toxicity of whole brain to SRS to brain metastasis. This must be corrected, not discussed, not argued, but corrected. And to the right, you can see our experience for AVMs. If you treat gamma knife a second time, the risk doubles. And if you give gamma knife following prior fraction radiation, the risk increases with a factor of 4. So for us, it was crystal clear that if you add radiation to radiation, the risk for side effect increases. This is published from MD Anderson, published 2009. And it showed that you add whole brain on radiosurgery, you double the number of patients with neurocognitive impairment. So this was a strong argument to omit whole brain radiation. And this is a recent published paper from the Congress of Neurological Surgeons in the US. And they say, as you can see here, up to 4 brain metastases, here's the number 4 again, you can give radiosurgery alone, and more than 4 metastases, you can give radiosurgery alone. So today I would say there is strong literature evidence that you can omit whole brain. You do not need to give it as a standard of care. What about the number of lesions that you can treat? And this has been very controversial over the years. As said, we said 4 lesions in the beginning, but we didn't always follow our own advice. This is a paper, an article published in Wall Street Journal. And this was based on one neurosurgeon in Miami, Isaac Wolf, who was very aggressive, treated brain metastasis with gamma knife. And he treated patients with 9 brain metastases. Dave Larson, a well-renowned radonc from UCSF, said, I don't think that's of a especially good case for treatment. So there was a strong opposition against this. But things change, and so does David Larson, as I hope I can show you in this clip.
The Electa gamma ray knife procedure at the hands of Dr. David Larson.
78 minutes to go.
All 24 tumors in her brain not only shrunk, they were gone.
And it's been a year and a half, and those tumors haven't regrown, and no new tumors have surfaced.
So obviously Dave Larson changed his mind, and he was so thrilled with the result and so thrilled with the patient who actually married her afterwards. Professor Yamamoto worked in Stockholm in 1988 and 89, and I taught him gamma knife. And this is one of the cases he showed in one of our meetings. A patient with 48 brain metastasis from breast cancer. And I said, this is absolutely madness. But if you look to the right, what is interesting is that no new tumors surfaced in this 6 months time period. And assuming there are numerous micrometastases at the time of gamma knife, obviously none of them grew to a visible size in this 6 months time period. Professor Takakura, the head of Tokyo Women's, also disliked this, so talked with Professor Stein in the US, and both condemned this treatment. And Takakura was so upset, he refused to become a co-author in Yamamoto's papers. The first paper really supporting the use of gamma knife for the benefit of radiosurgery, I would say, is this prospective randomized study published in Lancet. It concluded that if you give radiosurgery on top of whole brain, the patient lived longer with a better quality of life. However, if there's multiple lesions, there's no benefit to be found. So after this article, radiosurgery for single metastasis became standard of care. But for multiple metastases, the data was still weak. One reason may be that in this article, the treatment after randomization was free, which means the patient with the whole brain and had recurrences, that could be treated radiosurgery, and patient was still deemed to be in the whole brain arm. This is a paper published a couple of years later. And this is a randomized trial comparing whole brain plus radiosurgery versus radiosurgery alone for up to 4 brain metastases. And they concluded no benefit adding whole brain. Should be noted that the limit of this study was up to 4 brain metastases. So patient with more than 4 was not included in the study. But nonetheless, the reviewer, or the editor, wrote in his editorial, as you can see here, patients of more than 4 brain metastases should continue to be treated with the whole brain, without it being addressed in the paper at all. But again, so strong was the dogma in those times that more than 4 metastases cannot use radiosurgery. I think this is the first paper, at least as far as I know, who documented that the number of lesions have a limited impact on the prognosis. To the left, you see up to 2 years, and to the right, you see 2 to 5 years in the Stockholm material, but almost 2,000 patients. And what we clearly showed is patients with single metastasis had a better survival. But the patient with multi-metastasis who had 2, 3, or 4, 5, or 8, or more than 8, no difference in survival. And this was confirmed in a Japanese study published in Lancet. Single metastasis, they live longer, but 2 to 4 versus 5 to 10 brain metastasis, there's no difference in survival. So I think today most radiosurgeons at least agree that up to 10 metastases, there is strong documentation that you can use that without adding whole brain. And again, these are the guidelines from the CNS saying that you can use radiosurgery alone for more than 4 metastases if the total tumor volume is not too large. What was systemic treatment and impact on gamma knife? And I must admit, I'm a bit thin ice here, but I had looked through the literature before this talk, and I can give you some of my ideas. And probably most of you in the audience know more than I do about this. But this is a paper I find very relevant for us. This is a Japanese group analyzing about 600 patients, or 700 patients actually. Half of them had TKI and half of them not. And they find a trend that patients with TKI had a higher incidence of radiation-induced problems, but not significantly so. But also, there was more repeat treatment in the TKI group and more whole brain radiation, which certainly explains some of the difference at least. So based on this, there's no evidence that TKI increases the risk for radiation problems, but you could interpret the paper as being a trend of it being so. This is a review paper, 33 studies looking at immunotherapy and no relation between immunotherapy and radionecrosis, hemorrhage, or other complications. And this is another paper looked at the risk of radiation problems, and they found yes if whole brain, but no if radiosurgery. So my conclusion, which again is a bit weak, I would say that with the data I found today at least, systemic treatment should not affect the prescription dose for us. And you can consider interruption of TKI, assuming that can be done without jeopardizing the extracranial disease control. What about radionecrosis? And that is a major problem. We face it frequently. The patient has a tumor that increases in size, and the question is why? Is it because the tumor is growing, or is it because radiation-induced changes, typically called radionecrosis? But what is radionecrosis? Actually, it's a histological term, meaning dead tissue. And that was truly the case in the beginning. Here you're supposed to see, at least you can't see it, a radionecrosis for a patient with thalamotomy, a distinct necrotic lesion with unaffected brain around it. And on the MRI scan, you can see bilateral capsulotomies, again, generating radiation necrosis. But how to differ? And in the beginning, it was easy because we did give necrotic doses, which we don't do any longer. And that means like the upper case, the metastasis increasing in size, PET scan showed a cold spot. And below you see a metastasis increasing in size, and the PET scan with FDG tracer show hot spot. So at that time, I would say that FDG PET was quite conclusive. Another extreme case is also a patient with brain metastasis that almost disappeared. And then came this large lesion afterwards, and the PET scan shows it's completely cold. What about this, though? This is a patient treated for epilepsy. And as you can see, 9 months after the treatment, there was a significant radiation-induced reaction, which increased to 12 months. But 9 years after treatment, it's completely gone. Is this a necrosis? Obviously not. It's a temporary condition. So what is a good term? We tried to coin undue radiation effect, which hasn't really caught on. Radioreaction, radiocomplication. Does it matter? Yes, it does, because if you think of necrosis, you think if there's no circulation in the lesion, then there must be necrosis. But usually it's in inflammatory changes. You can have circulation, even if it is a radiation-induced complication. So there are a lot of methods used to try to differentiate between two. Time between gamma knife progression, if it happens after 6 months, more likely being tumor recurrence than radiation changes. You can do a biopsy, but even if a viable tumor, you can find necrosis and vice versa. You can do PET scan with FDG tracer, methionine, choline, use T1, T2 mismatch, MR spectroscopy, ASL, MR perfusion. But in my opinion, all are indicative and none is conclusive. So at the end of the day, you're standing here and you have to use a gut feeling to some extent. The good news is that if it is a tumor recurrence, it usually grows very, very slowly. So you can have the luxury to follow the patient rather than treat. These are two patients. The upper one, breast cancer, and 6 months after the treatment, tumor was gone. 1 year after, it recurred. Is it tumor recurrence or radiation reaction? The lower patient, 1 year after treatment, the tumor is slightly larger, but the contents enhancement is gone. That patient was given whole brain in an institution outside where I worked. These are the follow-ups. You see the upper patient disappeared, so obviously radiation changed. Lower lesion progressed continuously, and the patient has to pass by because of this. The patient was operated and was deemed to be tumor recurrence, but image-wise, to me, it looks more that radiation reaction. This is another patient of mine from US, a young woman with a metastasis from breast cancer. 3 months after, MRI looks perfect. Another year after, she has a big increase in tumor size. The T2 doesn't really give any information. We didn't dare to treat the patient. But today, if I look at the scans, I think it's more likely being tumor recurrence than radiation reaction. But again, there's no way to be absolutely sure. Another patient, 3 months after treatment, significant edema that completely normalized, and the tumor disappeared. What about management of patients with radiation changes? Steroids is a standard of care, but some use Avastin. There are several publications claiming a good response on Avastin. This is one article showing this. Here's another one, and here's another one, and here's another one. So there are documentation that Avastin may help for patients with radiation-induced changes. But the bottom line, at least as far as I'm concerned, there's no way to conclude a different tumor recurrence from undue radiation effect. Finally, I'd like to show work in progress. As Prof. Yo mentioned, we tried to push the border. And the only way to know where the border is to pass it. So we are now treating patients more than 20 brain metastases, and these are the preliminary results for the first 35 patients. This is one of the patients, a young woman, breast cancer, received whole brain, and the tumor recurred. And you can see to the left, there are the scans at gamma knife, and to the right, the follow-up. 4 months after treatment, the MRI scan looks pretty normal, actually. These are the survival times. The blue line represents the survival, and you see the median survival is a little bit more than 1 year as of now. The green line represents intracerebral tumor control, and that's about 50%. Here, intracranial tumor control is defined as the last MR shows no tumor activity, and that means if the last MR shows tumor activity, The patient's given, for instance, whole brain, and there's no more scans. It here defined as a failure. But you can also see the red line that most of the patients, actually 90% of them, do develop additional disease in the brain. An important factor is the condition of the patient, this ECOG quote. If the patient is normal, survival time is 2 years. If the patient is affected by the disease, survival time is half a year. So maybe we should reserve this treatment for patients in excellent condition. Volume does not play a role. More than 7 cc or less than 7 cc, which is the break point in many studies and many recommendations, but no impact on survival in our patient population. Here is, I think, with the best case we have, this prophylaxis patient, treated twice with gamma knife. Now it's almost 2 years ago. And as you can see, the MRI scan here is pretty normal. And here you can see prophylaxis together with the patient. I sort of blacked them out because of these PDPAs, and I hope this is acceptable. But 2 years following treatment, the patient is doing perfectly well, and the condition is excellent. So sometimes you are lucky in spite of a significant tumor burden to the brain. So the conclusion for me at least is that gamma knife does offer a high local tumor control rate, and we can deliver it independently of systemic therapy. I think we should omit whole brain unless it's evidence for leptomeningeal seed, unless there are special indications. Of course, it's a case-by-case decision, but shouldn't be given routinely. And the major challenge for me is not the number of lesions, but to differ between tumor recurrence and undue radiation effects. And I think if you have a patient in good condition with more than 20 brain mets, that should be considered for gamma knife surgery. I know this is a little bit extreme, but this is my personal opinion. Thank you very much for your attention.
Thanks, Bengt. Yeah. Any questions from anyone in the audience at all?
I do have a question for Dr. Ben Carlson. I'm an upper GI surgeon here, and just wondering about the tumor biology, because you're using gamma knife surgery for brain metastasis. Is there a differing response depending on the tumor type?
Well, the answer is yes and no. It's dose dependent. And there are studies looking at the malignant melanoma, which is rare here, as you know, and renal cell carcinoma, and they claim a poor tumor control rate. But the doses we give here usually wipes out this difference. I would say the tumor control rate for us is the same independent of histology. It's a dose question.
There's also a mention of using the robot to help guide gamma knife surgery. How does that help in treatment?
Well, the main difference is that you dock the patient in the machine, and the machine does the rest, which is save time. And also in the old machine, the patient you did one isocenter, the patient come out, the patient set up, you reset the coordinate, you dock the patient again, and so back and so forth. 1 or 2 isocenters, no difference, but 50 isocenters, a big difference. So the time saved we can use to treat more tumors.
Thanks, Professor Karlsson. Yeah, my question is a very basic question. What's the difference between gamma knife techniques compared to conventional radiotherapy techniques?
The main difference is gamma knife has 200 sources and the LINAC has 1 source, to make a long story short. And that means you can give sufficiently less doses surrounding brain tissue if you use a gamma knife as opposed to the LINAC. And that means also that the LINAC treating 20 brain metastases is inconceivable, because that means you're going to get the maximum dose somewhere in the brain.
You mentioned 20 sources of the radiation.
200.
200 sources.
Yes.
How to get these 200 sources?
They're in the machine. So that means that the dose fall-off is, or the penumbra, the dose fall-off is very sharp and the penumbra is low. And that means every time you position the patient, all the beams, 200 beams come to one spot. In LINAC, you have 1 moving beams. You can do cones, you can do standing fields, but that means a significant radiation amount comes to the surrounding brain tissue. For 1 lesion, you can argue the difference is insignificant, but the more the lesion that you treat, the bigger the difference.
But I believe the radiation oncology will harness these techniques to
No.
use to other cancers.
Harnessed, yeah, you mean radiosurgery?
Uh,
Yes, actually that is, thank you for the point, because the physicist I worked with in Stockholm in Malax, when we started using gamma knife, for metastasis, we just treated benign tumors because we didn't know, simply. And he know that you have to give a margin and so on and so forth, but he said it work in the brain, why doesn't it work in the lung? So he developed a device to treat radiosurgery in the body, and that is worldwide acceptance now to use SRS for extracranial disease.
Sorry, perhaps just one more question from me, which is also pretty basic. I mean, I think you and Professor Yeo both mentioned just now that you're pushing the boundaries in terms of the number of lesions that you're taking out. Other than the no leptomeningeal disease, which you mentioned just now, then what else would be an exclusion criteria? Is it dependent on the remnant volume of the brain or certain areas that you wouldn't be able to use the technique on?
Volume, yes. If the tumor burden is too large, then this is improper. But to me, the main parameter is the clinical condition of the patient. The patient has no evidence of disease. When you see the patient, that is a good candidate. Patient is bedridden, then obviously the benefit is very limited. So I think it's a clinical judgment more than image judgment.
Okay.
Any further questions? Yeah. Okay, if not,
Sorry, I think we do have one question from Dr. Mark Puendran, and he's asking if this technique is applicable to metastases at other sites like the bone.
No, the gamma knife is purely for brain, and the skull base you can use it as well, but otherwise no.
okay. If not, then thank you, Bengt, for a great lecture, and thanks everyone for the questions.